Hello, friends. Dave Bjork here, lung cancer survivor, patient advocate, and host of the Research Evangelist podcast. I just got back from ASCO annual meeting, the largest oncology conference in the world, and I'm doing a series of short interviews to provide some interesting research from ASCO for patients who could not attend the meeting. This series is supported by an unrestricted educational grant from Nuvation Bio. So today I've invited Dr. Melissa Johnson, a medical oncologist and the director of lung cancer research at the Sarah Cannon Research Institute, to tell us what we need to know about the phase 3 Libretto 432 trial. Dr. Johnson was one of the authors of the abstract presented at ASCO, and I'm really happy to have her on my show. So Dr. Johnson, welcome to the program.
Thank you, Dave, for having me.
Awesome. Great to see you.
Thrilled to be here.
Awesome. Great to see you. And so maybe let's just start by having you tell us about the trial, and we'll just what are the things that a patient would need to know that would be good takeaways that I can present to them through this show.
Thrilled to be with you to discuss Libretto 423. This was a randomized phase 3 trial for patients with early stage lung cancer. And in order to be eligible for the trial, patients had to have a tumor that harbored a RET alteration. So it's another oncogene that we see in lung cancer, affects between 2 and 4% of lung cancers, tend to be never or light smokers. And so in this study, patients whose tumors harbored RET alterations were randomized 1-to-1 to receive adjuvant selpercatinib, which is an oral RET inhibitor that's approved for patients in the metastatic setting. And this was after 4 cycles of chemotherapy. So the main takeaway is that patients that got selpercatinib had an improved overall survival hazard ratio in favor of treatment with selpercatinib, reducing risk of death due to cancer or any other cause by 83%. So this is a staggering result. It is, however, very similar to 2 other trials that have been conducted in the early stage setting. Same group of patients, only with EGFR alterations and ALK rearrangements. And those patients were randomized in a similar fashion to receive an oral EGFR inhibitor or ALK inhibitor versus placebo. And in both cases, the improvement in overall survival was 80% for those patients who had received the inhibitor. So that's amazing and great. And it's the fact that the Libretto data is consistent with these other 2 data sets, I think is part of what made this a stronger data set, and maybe one of the reasons that it was selected as a plenary presentation at ASCO. These trials are really hard to do with only 2 to 4% of patients having this particular alteration. We looked and looked and looked and looked and looked. And the trial actually in its final form was smaller than we had initially planned for it to be, but the power was there because the difference between those that got selpercatinib and those that didn't was so great. And so we believe that selpercatinib will be, its FDA label will be expanded to include after surgery. I think there's, though, some other implications of this work that are maybe the reason that it was included in the plenary. At academic centers in the United States and world over, I should say, this was a global trial. Most places where NGS testing is happening in a particular institution, it's being done for patients in this early stage setting. But I'll admit that at my hospital in Nashville, Tennessee, it's not done routinely for patients with early stage cancers. NGS testing isn't done. We have to date, we have only been able to request EGFR, ALK, and PD-L1, and those tests are standalone tests. So this Libretto data is likely the strength of data that we'll need to change the workflows at my hospital so that all patients with stage 1B to 3A cancers, irrespective of their smoking history, irrespective of their other medical history, will qualify for NGS testing. Because now we have three drugs that, when patients are treated with these drugs after surgery, it improves the number of patients that are cured. And so that's a pretty staggering statistic, pretty staggering improvement that I don't believe third-party payers or hospital systems will be able to argue with. So to me, that's the most significant part of this data.
That's amazing. And so really going to that earlier stage after surgery, uh, really emphasizing the need to get an NGS test, right? And we talk about biomarker testing all the time, this comprehensive biomarker testing, right? And so
Yes,
it sounds like when you compare the data to the ALK positive and EGFR, as you mentioned earlier, that's a strong case, and the results of this trial sort of confirming that and having additional strong case that could be a real way to change practices, not just at your hospital, but at a lot of other hospitals as well, right?
certainly in the United States, it will change practice a lot of places. And you can say to your doctor, who might say, "Oh, well, we don't see that very often," or, "Well, but EGFR is, 5 to 15%, and ALK is 5 to 8%. So that's at least 20% right there. Plus RET now is 2 to 4%." And then you start to think about all the other small uh, uh, groups of patients with alterations. ROS1 would be a big one, maybe BRAF V600E as another KRAS coming in future years. Those patients are going to add to the list. So you see that the pie is increasing in size, and more patients, even in that adjuvant setting, could benefit from knowing that information up front. Of course, the bigger challenge is getting that testing done in the neoadjuvant setting, like before surgery. And so that's still probably a few years and some iterations in technology yet away, because the amount of tissue you need is enough that not all bronchoscopy specimens will be enough for that testing to happen. But that's what really good looks like.
But we're making progress, and that's
100%.
that's what excites me. And when I was talking with Dr. Nasser Hanna recently about this, and it's like, we celebrate, but yet we also have to be empathetic to, that not everybody's going to get access to this or whatever. So, but the research itself on its own is really exciting. And I can see where the path is going from where we were 5 years ago, 10 years ago, 15 years ago. And that's why I'm so grateful for the work that you do, and others, around the world who are doing amazing research that is making a difference to help extend the lives of patients. But I'm excited about the earlier stage too. I think that's what's really exciting to me about this.
Yeah, I agree with you, Dave, and I think I'll be honest with you that I remember when I came to Sarah Cannon now 11 years ago, and David Spiegel, my boss, was
Yeah.
talking about curing more patients with lung cancer, and I thought, why are you talking about that? That's not what we're able to do, but yet now we are, and it's because of optimistic thinkers like David that helped us see that this was possible, one bite at a time, one step at a time, so that now we're starting to talk about the questions of sequence of therapy between adjuvant and metastatic, the way my colleagues that take care of breast cancer patients have been talking to their patients about those things for years and years. So I see a lot of forward progress for sure.
Yeah.
It's a lot to be grateful for and thankful for, but again, there's lots of work to do.
Yeah. Well, this is very exciting, and I know it got chosen. This research got chosen to be in the plenary session, which I did attend, which was very cool. There was a lot of really,
Yeah.
really great research that was presented that day.
It was a
So
memorable plenary for sure.
it really was. It was excellent. And so anyway, I appreciate you coming on the show and sharing your thoughts about this and this important research. And I'm really looking forward to sharing it with my audience. And again, thank you for all you do for the lung cancer community. And thanks for being on the show.
Oh, my pleasure. Thanks for having me. It was the bright spot in my day.